Assalamu alaikum and good morning, everyone. I welcome you all in this core urology session today, which is to be presented by Dr. Farooq, and the topic is on non-neurogenic lower urinary tract symptoms. So, please, Dr. Farooq, start.
Assalamu alaikum. My name is Dr. Farooq. I am a resident of Urology. Today's our topic of discussion is the non-neurogenic LUTS, lower urinary tract symptoms. Our outline of discussion is the epidemiology, symptomatology, IPSS, UFM, and post-wide volume. Introduction. Male LUTS are highly prevalent and increase significantly with aging. They include storage, voiding, and post-micturition symptoms, which can impair quality of life. Storage symptoms are common, often under-recognized, and contribute substantially to patient bother. LUTS are associated with modifiable risk factors such as metabolic syndromes and may offer targets for prevention. Moderate to severe LUTS may also be linked with increased cardiovascular risk and growing healthcare burden.
Here I want to mention that what I have read in the literature, that the lower urinary tract symptoms, the non-neurogenic lower urinary tract symptoms, they are particularly related to the number of the modifiable risk factors, which are the obesity, diabetes, hypertension, and the metabolic syndromes. And many of the persons who present to us, and as per the guidelines, those who presented to us in our OPDs and ERs with the moderate to severe LUTS, they are at very high risk for developing the aggressive and severe cardiovascular events. So in this way, we can have a close follow-up on these patients as well in regards to the cardiac status.
The epidemiology, the storage symptoms are the frequency, urgency, nocturia, and incontinence are the most common. It accounts for the 57% globally. And on the other hand, 36% voiding symptoms and the 31% post-micturition symptoms. In multiple countries, nocturia and urgency are leading symptoms. 33% of adults reports moderate to severe symptoms scores on the IPSS or the similar tools. LUTS are linked to worse quality of life, anxiety, depression, and impaired sexual function.
Okay, so these are the statistics that are actually taken from this reference that is mentioned at the bottom of the screen, or you can see over here. So this is so far the largest meta-analysis that has been done back in 2022 and published in Korean study, and this was based on 222 studies. And it showed that globally that most of the patients, they do present with not the voiding symptoms but the storage symptoms, that comprising of 57% globally, and voiding symptoms are actually 36% with the 31% post-micturition.
The symptoms, the storage symptoms include the urgency, frequency, nocturia, and the urinary incontinence. And the voiding symptoms are the hesitancy, intermittent urination, straining, and the poor flow. Post-micturiation symptoms include the post-void dribble and the sense of incomplete emptying.
Okay. So here we mentioned the division of non-neurogenic lower urinary tract symptoms in 3 categories. And as these statistics have already been mentioned by Dr. Farooq in the last slide, that majority of the patients do present with the storage symptoms, not the voiding symptoms. So can anyone please tell me that what is the pathophysiology behind the storage symptoms as the name indicates itself? Yes, any volunteer? जी डॉक्टर सुलेमान. Yes.
Someone else.
Javed.
चलो, let me rephrase the question. सब कुछ हो क्यों रहा है? क्योंकि प्रोस्टेट बड़ा हो रहा है. जब प्रोस्टेट बड़ा होगा तो सबसे पहले तो यूरिन रुकेगा ना. पुअर स्ट्रीम हो रही है, इंटरमिटेंसी हो रही है, हेजिटेंसी हो रही है. लेकिन जब आप ओपीडी में जा रहे हैं तो पेशेंट आपके पास फन लेकर आ रहा है, फ्रीक्वेंसी, अर्जेंसी, नॉक्चूरिया, बाकी सिम्टम्स तो लेके ही नहीं आ रहा. पूछे भाई किस शिकायत से आए हो? सर बार बार पेशाब आ रहा है तो कंट्रोल नहीं हो रहा है, रात में उठना पड़ रहा है. मेजोरिटी ऑफ द टाइम कंप्लेन यही है. अभी इन्होंने बताया कि लिटरेचर कहता है कि 56% जो है वो स्टोरेज है और 36% जो है वो वार्डिंग सिम्टम्स है. तो व्हाई इज इट सो? ऐसा क्यों है?
सर जो स्टोरेज सिम्टम है इस पेशेंट के, सर ये सर ये bothersome है ना, इससे पेशेंट की नींद खराब होती है, बार बार पेशेंट को पेशाब करना पड़ता है इससे सर।
Okay, so storage symptoms, as the name indicates, that storage. So something has to do with the bladder capacity, the something that is going inside the bladder walls. So this is related to the holding capacity of the bladder. अगर समझ में आ रहा है आप लोगों को तो इसमें जो है basically what will happen that whenever there is a long term chronic obstruction down there in the lower urinary tract symptoms, so bladder has to act against it for a longer period of the time. So there will be some modifications that will be done over the period of the time inside the bladder. Some modifications will be done, that is the loss of the elasticity and else. So what happens is that because the bladder has become so thick walled, loss of elasticity is there. So with the passage of the time, it actually presents against the obstruction with the detrusor overactivity comprising of urgency, urgent continence, and the frequency. That is, it will hypersensitize itself from the urine. Even with the small mils of the urine volume, this will not be tolerated by the bladder and will be urgently expelled out from the bladder. And apart from that, not only this detrusor overactivity, it will also result in the reduced compliance of the bladder. Since the elasticity has been reduced, so this will result in the reduced compliance of the bladder and ultimately a less room for the volume storage of the urine.
The storage LUTs include the frequency. The normal frequency is about the 5 to 6 times per day with almost 300 ml per void is a normal. And the urgency is sudden uncontrollable need to urinate. And the nocturia is 2 times or
Yes.
यानी कि स्टोरेज के बाद की consequences on the bladder. What is the pathophysiology of the storage of the bladder? Again.
डॉक्टर शशि जो हमारा हम जो चल रहे थे ना लेके उसको थोड़ा सा मैं और डॉक्टर मरियम की बात में ऐड कर देता हूँ. इट इज लाइक के जो नेचुरल हिस्ट्री ऑफ द डिजीज है ना दैट इज सेम कि इनलार्ज प्रोस्टेट हुआ, बेसिकली आउटलेट पे एक ऑब्स्ट्रक्शन आपने खड़ी कर दी है, दैट विल कॉज द वॉइडिंग सिम्टम्स. वॉइडिंग सिम्टम्स आर व्हाट? हेजिटेंसी, इंटरमिटेंसी, पुअर स्ट्रीम, थिंग्स लाइक दिस. These are symptoms, but our population is ignoring these symptoms. They usually come to you and they have bothersome LUTs. So what are the bothersome LUTs? These are the bothersome LUTs because these symptoms are affecting their daily activity. These symptoms are affecting their daily. अगर frequency है, urgency है, nocturia है, तो उनकी life affect हो रही है. Then only they come to you. So what Dr. Mariam was explaining कि ये हो क्यों रहा है? ये basically जो आपने outlet पे obstruction खड़ी कर दी है, now your bladder is working against the resistance. That resistance will cause hypertrophy of the bladder wall. That hypertrophy of the bladder wall decrease the functional capacity of the bladder. यानी initially अगर आपकी 500 की capacity थी और आपको 300 पे अर्ज आ रहा था यूरिन का, now the capacity has reduced to 300. So अब आपको 100 cc पे भी अर्ज आएगा यूरिन का. और that hypertrophied mucosa has certain other features जो आगे चल के बताएंगे कि वो urgency कैसे करा रहा है, वो nocturia कैसे करा रहा है. So ये पूरे का पूरा एक प्रोसेस वहां से स्टार्ट हो जाता है. तो that is the pathophysiology.
डायवर्टिकुली जो है ये इशू होती है
जी.
अगर किसी को डायवर्टिकुलेशन हाइपरट्रोफी मसल्स होते हैं तो उसमें गैप बनते हैं और वो हो जाते हैं. इसी तरह ट्रेन पे जो है ना मल्टीपल डायवर्टिकुलाई बनते हैं तो लार्ज डायवर्टिकुल बन जाता है. तो ब्लैडर की फंक्शनिंग कैपेसिटी वो जो है आउट एक्सपेक्ट करने की वो कैपेसिटी रहता है. इट इज जस्ट लाइक ए हार्ट. इसमें पेरिफेरल रेजिस्टेंस जब बढ़ता है तो हार्ट इनलार्जमेंट होता है, लेफ्ट वेंट्रिकुलर हाइपरट्रोफी होती है. सेम वे इसी तरह ब्लैडर भी एक्ट करता है.
Yes, against the chronic obstruction.
कि जो resistance, once resistance has not been removed, then it will there will be myogenic changes. जो collagen deposition है वो start हो जाती है वहाँ पे bladder wall पे और ultimately decompensated phase आ जाता है जिसमें फिर then blood circulation और जो सर बात कर रहे हैं.
Dr. Mazahir, can you hear us? इनका माइक तो खोले.
नहीं, इसका
बंद है यार, सामने दिख रहा है बंद है.
अस्सलाम वालेकुम, बिल्कुल आवाज आ रही है.
सर इसमें ऐड करेंगे आप, ये पैथोफिजियोलॉजी को लेके बच्चे परेशान हैं काफी।
Gigi. So basically, the pathophysiology is the intravesical obstruction. The enlarged prostate decreases the caliber of the urethra, and now the bladder has to compress, push the urine across a prostate which is obstructing. इसमें काफी फिजियोलॉजी आती है. फॉर एग्जांपल लैप्लेस लॉ हो जाता है कि जो सर्कमफ्रेंस ऑफ द यूरेथ्रा है वो कम हो जाता है फ्रॉम द प्रोस्टेट. All these factors increase the resistance of the urine flow across the prostate. Now the bladder is working to just simplify. For example, if the pressure across the prostate from the enlarged prostate is now increased to 10, so the bladder has to generate a pressure of say 15 centimeters of water to push the urine across that prostate. So what happens now? It's working against resistance. जैसे प्रोफेसर मुनव्वर ने कहा है कि it's like a heart. तो hypertrophy होना शुरू हो जाएगा. The mucosa and the muscularis muscles will begin to hypertrophy and increase the pressure to pass across the urine. If that is where the bladder is compensating, then there is changes in the mucosa where there's hypersensitization, and the trigone is the most sensitive part. So this hypersensitization, what happens that when even the small amount of urine comes, because of this hypersensitization, the bladder will become irritable, overactive हो जाना शुरू हो जाता है, which is why the frequency and the nocturia. Then as the obstruction keeps on progressing, what happens that rightly said by Dr. Furkani, that the collagen, which is different in the normal epithelium, starts to be replaced by a more rigid collagen. And then the sequelae of chronic obstruction, diverticular formation, circular formation, because of the increased work, they continue to keep on progressing until the patient becomes so bad that he goes into absolute acute urinary retention. So the pathophysiology is the change in dynamics of bladder outflow and the change in the epithelium sensitivity, which leads to the sequelae of chronic obstruction.
राइट सर, चले जी.
Nocturia is the 2 times or more than 2 times voiding during the period of sleep, or the voiding preceded and followed by the sleep. The urological causes include the benign prostatic obstruction, or the overactive bladder, incomplete bladder emptying. The non-urological include the renal failure, diabetic mellitus, or the diabetic insipidus, and the primary polydipsia. Urinary incontinence is the involuntary passage of urine. Stress incontinence is the involuntary passage of the urine with the activity that increases the intra-abdominal pressure. And the urge incontinence is the involuntary passage of urine coincident with the sensation or the urinary urgency. And the mixed urinary incontinence patient have the urinary urgency with the loss of urine and the loss of urine with Valsalva manures or increased intra-abdominal pressures. The continuous incontinence is the constant wetness that is independent of the urge to urinate or manure associated with the increased intra-abdominal pressures. The overflow incontinence occurs when the urine within the bladder exceeds the bladder capacity. It's the result of increased intravesical pressure more than the urethral outlet resistance. And the intermittency
So
is
now comes the voiding lower urinary tract symptoms: intermittency, hesitancy, post-micturition, dribbling. So basically, these will be the symptoms that will be exerted against the outlet resistance. The previous one was because of the bladder dysfunction due to the chronic obstruction down there in the lower urinary tract. Now this occurs because of the against the resistance that is there. So bladder will act against these resistance, and it will result in Dr. Farooq.
the intermittency is the involuntary stop and start of micturition due to the intermediate obstruction of the flow. It is mostly due to the vesical calculus or the enlarged prostate. And the hesitancy is a trouble to start urinate or maintain urinary flow. And the post-micturition dribbling is the involuntary loss of drops after individual completing voiding. The causes of LUTS include the benign prostatic enlargement.
So what are the other causes of lower urinary tract symptoms apart from the benign prostatic obstruction? Ji. What are the other causes of the lower urinary tract symptoms? That will. Yes. Who can? Ji, Dr. Zubair.
And it could be urethral stone. High bladder neck.
That is called primary bladder neck obstruction. Okay. Okay. Can urinary stone at the UO can cause the lower urinary tract symptoms? Can bladder growth cause the lower urinary tract symptoms? That's it. You know, bladder stone भी कर सकता है. और can diabetic cystopathy cause the
डायबिटिक सिस्टोपैथी में भी हो सकता है, ठीक है. और if the patient is suffering from CNS problem like PD, Parkinson's disease, MS, then there may be a possibility of lower urinary tract symptoms with detrusor overactivity and DSD. And if the patient is suffering from the spinal cord injury, or there is a congenital problem in the spinal cord, and there is a meningeomyelocele, then they can lead to the lower urinary tract symptom that is called neurogenic bladder. Okay, if the patient is suffering from lower urinary tract symptoms, then the cause in the CNS and spinal cord, then this is called neurogenic bladder. And what is Hinman syndrome? Hinman syndrome can cause
Distal ureteric stroke can cause LUTS, or certain drugs can
Hinman
cause.
syndrome आप लोग पढ़ लीजिएगा, ठीक.
The causes include the benign prostatic enlargement and underactive bladder or the detrusor underactivity. And
कोई रिपीट कर देना भाई सब.
Yes.
जब भी लोअर यूरिनरी ट्रैक्ट सिम्टम्स का पेशेंट आता है तो आपको ये सब कुछ सोचना है. तो कौन रिपीट करेगा? जो पीछे बैठे होते हैं ना दुनिया में.
जी डॉक्टर हबीब.
हाँ चलो.
नॉन प्रोस्टेटिक enlargement symptoms में हेजिटेंसी, अर्जेंसी, इंटरमिटेंसी और उसमें जो causes.
नहीं यानी आप कॉजेज बताए ना.
जी
कि if the patient comes with the lower urinary tract symptoms, then what are your differential diagnosis? अभी पढ़ ले भाई.
benign prostatic enlargement, benign prostatic obstruction.
भाई अभी मैंने आप कॉन्सेप्ट बनाया ना. अभी मैंने क्या कहा था कि मीएटस से स्टार्ट करो. देयर में भी मीएटल नैरोइंग. फिर मीएटस के बाद क्या आता है? यूरेथ्रा आता है.
यूरेथ्रा स्ट्रक्चर.
हाँ, फिर उसके बाद आगे क्या आता है?
benign prostatic.
हाँ, फिर उसके बाद वहां पे ब्लैडर नेक प्राइमरी ब्लैडर नेक ऑब्स्ट्रक्शन होता है.
हाई ब्लैडर नेक और ब्लैडर स्टोन आता है, वेसिकल स्टोन आता है.
सो इसमें मैं एक पॉइंट ऐड करना चाहूंगा. हमारे एक सीनियर है, वो नहीं है, मतलब चले गए बाहर. वो जब हमें लॉन्ग केस की तैयारी कराते थे ना, तो जब हम उन्हें डीटी में कहते थे ना कि ये इलाज प्रोस्टेट है, तो उसके बाद हमें आधे घंटे की डांट मिलती थी. और ही ऑलवेज सेड दैट ये जो बीपीई है ना, बिनाइन प्रोस्टेटिक एनलार्जमेंट, दिस इज डायग्नोसिस ऑफ एक्सक्लूजन. जब आपने ये बाकी सारे सर्कल एक्सक्लूड कर दिए ना, तब आप कह सकते हैं बिनाइन प्रोस्टेट. वरना आपके लॉन्ग केस में डिफरेंशियल डायग्नोसिस पे एग्जामिनर इस बात पे अड़ा रहेगा कि ये बिनाइन प्रोस्टेट है ही नहीं, ये लार्ज प्रोस्टेट है ही नहीं, ये कुछ और है, ये एसटीडी है, ये यूरिनरी स्ट्रक्चर है, ये वो. तो वो हमेशा कहते थे कि आप डायग्नोसिस ऑफ एक्सक्लूजन बनाएं इसको, जब आपने बाकी सब चीज़ों को अपनी हिस्ट्री में और एग्जामिनेशन में किसी हद तक रूल आउट कर दिया है, देन ओनली यू कैन से कि भाई ये मुझे लग रहा है कि ये लार्ज प्रोस्टेट हो सकता है.
एंड वी आर मिसिंग नॉक्टर्नल पॉलीयूरिया, so it is very important. So what is nocturnal polyuria? क्या होता है भाई? मरियम कुछ बता दो.
Yes.
गुड.
So
तो आपको कैसे पता चलेगा कि more than 2/3 पास कर रहा
So there is an index, nocturnal polyuria index, that we can calculate. It is an index basically between the urine that is formed in at the night divided by the total 24-hour urine volume. So here we can have the nocturnal polyuria index at
और
the end of it.
दूसरा एक सिंपलेस्ट हमारे पास भी है. हमें
FPC, bowel diaries.
हाँ, क्या कहते हैं? ब्लैडर डायरी.
Frequency-
ब्लैडर डायरी या फ्रीक्वेंसी वॉइडिंग वॉल्यूम चार्ट बना सकते हैं. तो जब भी कोई पेशेंट आता है लोअर यूरिनरी ट्रैक्ट सिम्टम्स का, अगर आपका जो है वो आपको जो है डायग्नोसिस के लिए या फिर जो है इन्वेस्टिगेशन में आपने अपनी जो है ब्लैडर डायरी भी डालनी है. ठीक है. ब्लैडर डायरी इज एसेंशियल पार्ट ऑफ डायग्नोसिस एंड इन्वेस्टिगेशन of lower urinary tract symptom. If you will not put the bladder diary, then you can miss the nocturnal polyuria.
ब्लैडर डायरी कितने दिन होनी चाहिए?
It is recommended that
At least 3 days.
At least 3 days, 3 to 5 days is enough, I think.
For the compliance, it can be done for more than 3 days.
ब्लैडर कैपेसिटी इससे पता चलेगी, अर्जेंसी, इनकॉन्टिनेंस का पता चलेगा. और इफ यू आर गोइंग फॉर फर्दर इन्वेस्टिगेशन लाइक यूरोडायनेमिक्स, तो उसमें आपको ब्लैडर डायरी हेल्प करेगी कि
ओके।
इसमें जो एक चीज हम मिस कर रहे थे ना अभी, जब आप बहुत सारी चीजें बताई आपने, अभी हमने पढ़ा नहीं पूरा, तो आप देखेंगे बीपीओ के बाद जो है ना वो अंडर ब्लैडर की बात हो रही है। अभी मैं एक पेपर पढ़ रहा था, तो उसमें वो कह रहा है कि अगर बीपीओ आपने एक्सक्लूड कर दिया ना कि भाई मोर देन 10 यूएफएम है और पोस्ट फाइट रेजिड्यू नहीं है, तो देन जो सेकंड चीज आ जाती है वो अंडर ब्लैडर आ जाता है, कि उसको जरूर देखें, क्योंकि उसमें भी आपको वही सिम्टम्स मिलते हैं जो बीपीओ में मिलेंगे। अगर क्यूमैक्स बताता है कि भाई मोर देन 10 है और पोस्ट फाइट नहीं है, तो अंडर एक्टिविटी को हमें जरूर देखना चाहिए, क्योंकि वरना अगर आपने इनलार्ज प्रोस्टेट को ट्रीट कर भी दिया तो उस मरीज को सीआईसी की जरूरत फिर भी पड़ेगी। तो एक तो काउंसलिंग में वो अच्छा रहता है कि मरीज को आप बता दें सर्जरी तो कर रहे हैं, मगर हो सकता है आपको फिर भी सीआईसी करनी पड़े, या सीआईसी में थोड़ी आसानी हो जाएगी, ऑब्स्ट्रक्शन रिलीव हो जाएगी। तो अंडर एक्टिविटी को जरूर हम इसमें, उन्होंने भी सेकंड नंबर पे अगर ऐसे घूमे तो है भी ऐसे ही, तो सेकंड नंबर पे अंडर एक्टिविटी है, फिर बाकी चीजें आती है।
वो डायबिटिक, उसमें जो है वो लाइकोसूरिया के केस में भी एक्सेसिव यूरिन फॉर्मेशन होती है, क्योंकि ग्लूकोज जो है वाटर को
Osmotic diuresis.
ऑस्मोटिक है। दूसरा जो है कार्डियक कॉज होता है, जब लाइन डाउन पोजीशन में होता है तो रीडिस्ट्रीब्यूशन ऑफ फ्लूइड होता है और उसकी किडनी में परफ्यूजन इंक्रीज हो जाती है और एक्सेसिव यूरिनेशन होती है जब लाइन डाउन। ठीक है, तो ये इसके nocturnal polyuria के भी cause-
Yes, there are multiple causes of polyuria, nocturnal polyuria, diabetes insipidus, diabetes mellitus, excessive intake of the water. So, next slide.
The evaluation of the LUTS start with the medical history. A medical history aims to identify the potential causes and the relevant comorbidities, including the medical and neurological diseases. In addition, the current medications, lifestyle habits, emotional and psychological factors must be reviewed. The summary of the evidence: a medical and the surgical history is integral part of a patient's medical evaluation. And the medical and surgical history aims to identify the potential causes of LUTS as well as any relevant comorbidities and to review the patient's current medications and the lifestyle habits. And the recommendation from the UA that take a complete medical and surgical history from men with LUTS.
So, please go back. So, when a patient comes to you with the lower urinary tract symptoms in the OPD, how are you going to evaluate this person? Yes.
बकवास है भाई, बताओ। पीड्स में हो तुम बहुत, पीठ से निकल ही नहीं रहे।
ये वो कह सकते हैं पीठ में प्रोस्टेट नहीं होता।
सर प्रोस्टेट के अलावा जो है ना लोअर ट्रैक्ट पूरा
सर
होता है।
डिटेल हिस्ट्री लेंगे।
हिस्ट्री में क्या पूछेंगे भाई?
आप कैसे ओपीडी 14 में एक पेशेंट आया है,
आप क्या पूछ रहे हैं?
आप क्या स्टार्ट कैसे करेंगे?
हाँ हाँ बताओ, जुबैर बता देगा।
जी हबीब।
जुबैर साहब कुछ कहना चाहते हैं? उसको पूरा बायोडाटा लेंगे, वो ले लिया, जल्दी जल्दी बताओ, टाइम नहीं। पूछेंगे, ट्रेनिंग पूछेंगे, लोअर यूरिन ट्रैक्ट सिम्टम्स की हिस्ट्री ले ली, फिर क्या और कुछ पूछेंगे? रेड फ्लैग साइन, व्हाट आर द रेड फ्लैग साइन इन लोअर यूरिन ट्रैक्ट सिम्टम्स? कौन से रेड फ्लैग साइंस होते हैं जिसमें आपको कान खड़े हो जाने चाहिए? अगर किसी को बीपीओ है तो क्या होगा?
अपर ट्रैक में
रिटेंशन होगी। और अगर किसी को ब्लैडर ग्रोथ है उसके साथ जो है लोअर यूरिन ट्रैक्ट मेचूरिया होगा। तो दीज आर द, और अगर कोई साइंस ऑफ रीनल फेलियर हैं, अगर कोई किसी को जो है एनोरेक्सिया है, वॉमिटिंग है, तो ये सारे रेड फ्लैग साइंस होते हैं लोअर यूरिन ट्रैक्ट सिम्टम्स के लिए। ठीक है, वेट लॉस हो रहा है। अच्छा, फिर उसके बाद क्या करेंगे, क्या पूछेंगे? भाई सारे हेडिंग्स होती है ना हिस्ट्री की, ठीक है, कि जिसमें एचओपीसी होता है, फिर पास मेडिकल हिस्ट्री होती है। आप जब भी आपको हिस्ट्री पूछे ना तो आप इसी तरह बताएं, पास मेडिकल हिस्ट्री, पास सर्जिकल हिस्ट्री लेंगे, फिर उसके बाद उसकी बाउल हैबिट्स और डाइटरी हैबिट्स के बारे में पूछेंगे, और फिर उसके बाद फिर जो है वो उसकी जो है वो सोशियो इकोनॉमिक। तो इस तरह हिस्ट्री जब भी आपसे पूछे तो आप हेडिंग्स में बताएं कि ये मैं पूछूंगा, ठीक है। फिर क्या करते हैं मरियम?
The symptom focused clinical assessment, clinical history will ask about the IPSS 7 symptoms, and that one is the quality of life, and the fluid and caffeine intake, the constipation, and medications history like the diuretics, use of diuretics or the anticholinergics or the opioids, and the comorbidities like the DM, diabetes, cardiac or the renal diseases, and the prior history of the catheterization or the surgery history.
अच्छा, it is very important to give the chart of IPSS to the patient. अभी अगर उर्दू में हम जो है वो कर लें और फिर उसके बाद फिर पेशेंट को दे दें और फिर उसके बाद उस पेशेंट से ऑब्जेक्टिव असेसमेंट हो जाती है। तो IPSS is the objective assessment of the symptoms of the lower urinary tract symptom.
जी, Dr. Zarak, what is the IPSS? Can you briefly describe?
जल्दी जल्दी बोलो, कोई टाइम।
सर सिम्टम्स में सर फ्रीक्वेंसी, इंटरमिटेंसी, अर्जेंसी और वीक स्ट्रीम और स्ट्रेनिंग आती है। इसमें स्कोरिंग होती है
नहीं
0 to 6
7 है ना, 7 फनीश है ना।
But there is a particular statement of each question.
चलो, और फिर उसके बाद सिम्टम्स के बाद भी कुछ आता है ना।
स्कोरिंग होती है सर, और क्वालिटी ऑफ लाइफ, के वो उसमें भी 6 points.
Whether the symptoms are bothersome to the patient or not. So IPSS is the combination of lower urinary tract symptoms and the quality of life questions. So that is the difference between AUA. The only difference between AUA, American Urological Association symptoms score, and IPSS is that IPSS include the quality of life questions. Okay. So it is very important that you have to ask that whether the frequency is bothersome to the patient or not. He is delighted or the life is terrible, or if the nocturia is bothersome to the patient or not. Whether the quality of life is terrible or he is delighted, no problem. So, okay. So all the management depends upon the bothersome symptoms. Okay.
We look for
It is very much important to give the IPSS to every patient if the patient comes to the to our clinic. Okay.
मैडम एक चीज और मैं ऐड करूंगा, ड्यूरेशन ऑफ सिम्टम बड़ा इंपॉर्टेंट है। वो हम अक्सर मिस करते हैं। ओपीडी में हम देखते हैं ना, सर इसको लेफ्ट नंबर पेन है, तो मैंने कम देखा है कि लोगों ने लिखा हो कि कब से है, अक्यूट है या पिछले 2 साल से चल रहा है, 1 साल से। तो वो ड्यूरेशन बड़ा इंपॉर्टेंट है। अगर स्कोरिंग को भी देखें तो उसमें भी यही है ना कि पिछले इतने दिनों में आपको कितनी दफा ये हुआ, तो ड्यूरेशन ऑफ सिम्टम्स या डिजीज बड़ा अहम है। उससे क्रॉनिसिटी और अक्यूट ऑनसेट का पता चलता है, फिर आप उसी तरह डायग्नोसिस बनाते हैं उसकी, या डीडी में उसको डालते हैं।
We will look for the visible hematuria, recurrent UTIs, pain, fever, acute retention, or the renal impairment, and the hydronephrosis and neurological. This is the IPSS International Prostate Symptom Score. It has 7 symptoms.
It comprises of total total of 8 questions. 7 questions based on the patient's symptom, mixed of particularly avoiding symptoms, and 2 questions comprising of the storage symptoms. And the 8th question is about the quality of the life. And for each questions, there will be a category from 0 to 5 for which the patient has to mark about his desired status of the condition, current condition. And one thing that you may notice that all of these questions, the 7 questions, will be asked with respect to over the past month. Like in the last past month, how often have you had this, and that? So in the last past month, it is categorized. Next.
The IPSS is categorized into asymptomatic if he has the 0 points, and the mildly symptomatic 1 to 7 points, and the moderately symptomatic 8 to 19 points, and the severely symptomatic 20 to 35 points. The 0 is the excellent, and the 35 is the worst score. Recommendations use from the EUA. Use a validated symptom score questionnaire, including bother and the quality of life assessment during the initial assessment of male LUTS and for the re-evaluation during or after treatment.
Next.
The FVC frequency volume chart and the bladder diaries. The recording of volume and the time of each void is referred as a frequency volume chart. Inclusion of frequency volume, inclusion of additional information such as the fluid intake or the use of number of beds or the activity during the recording and the grades of symptoms and severity and the bladder sensation is called bladder diary. The bladder diary is ideally for 1 week, but at least 3 days is required to assess LUTS. It gives the insight into the functional capacity of the bladder and help quantify the severity of the nocturia. The summary of evidence from the EUA, frequency volume chart, and the bladder diaries provide real-time objective documentation of urinary symptoms and reduce recall bias. 3-day FVC provide reliable measurement of urinary symptoms in patients with LUTS, similar to 7 days and without losing the diagnostic accuracy.
Okay, so with this frequency volume charts, what are the parameters that we can have if the patient comes with this FVC? Ji, Dr. Hidayat.
And what is the difference between frequency volume chart and bladder diaries? Is there any difference or not? Both are similar?
They are different.
तो बता दो भाई नजम लोगों को बोलते हैं.
In frequency volume chart, you only measure the urinary output, the volume of urine that is passed. In bladder diary, it also includes the intake, output, and when patient had incontinence or not, number of pads used.
So basically, you can have at the end 24-hour urine volume, daytime frequency, the nocturnal frequency, the divided volume of each void as per the frequency, and if there is any leak in between, and if the patient has charted the desirable amount of the fluid intake from it. So after
This is bladder diary.
Yes.
Okay.
Yeah. The physical examination and the DRE is the important the evaluation of the LUTS. The physical examination focusing in a particular on the suprapubic area and the external genitalia and the perineum and the lower limbs should be performed. The summary of evidence from the UA physical examination is integral part of patient's medical evaluation. DRE can be used to assess prostate volume and texture. However, the correlation of the to the actual prostate volume is poor by the DRE. Recommendation: perform a physical examination including DRE in the assessment of male LUTS.
So you have to examine the genitalia, you have to examine the abdomen, you have to examine the abdomen, you have to examine the genitalia, you have to do the DRE, you have to do the focused neurological examination of the lower limb. The focused neurological examination of the lower limb include sensory, motor, and reflexes of the lower limb. Okay. So it is very much important to do the examination. If you miss the examination, then you can miss the diagnosis. Suppose the patient's coming with the lower urinary tract symptoms and you have not examined the back and you have not done the DRE, and it is because of any spinal problem. So you can miss the findings. So every patient comes with the lower urinary tract symptom is not BPE. There are so many diagnoses, and if you will not take the good history and you will not do the good examination, then you can miss it. Okay.
So urine analysis is again very much important when it comes to the evaluation of the lower urinary tract symptoms. And basically, you have to find out if the culture is positive, if there is an active UTI going on. And other than that, we can also look for the glycosuria, as Professor Munawar has just said, in case of the diabetes patient, and also to look for the microhematuria. Then recommendations, Farooq? Recommendations.
The recommendations for the urine analysis. A urine analysis may indicate urea, proteinuria, hematuria, or a glycosuria requiring further assessment. And the benefits of urine analysis outweigh the costs. And the use urine analysis in the assessment of the male LUTS have a strong strength rating in the EUA. Serum creatinine level, summary of the evidence from the EUA. Decreased Qmax and a history of hypertension or diabetes are associated with CKD in patients who present with LUTS. Patients with renal insufficiency are at increased risk of developing post-operative complications. And the recommendations assess renal function if renal impairment is suspected based on history and clinical examination, or in the presence of hydronephrosis, or when considering surgical treatment for the LUTS. The PSA and the prostate volume. PSA can help estimate prostate size and predict the likelihood of the enlarged prostate or the BPO. A PSA of more than 1.5 nanogram per ml often suggests a prostate volume of 30 or more than 30 ml. For predicting prostate volume more than 40 ml, age-specific PSA cutoff or approximately if the PSA more than 1.6 nanogram per ml in the 50s, and the more than 2.0 nanogram per ml in the 60s, and more than 2.3 nanogram per ml in the 70s. Thus, the PSA is not only a cancer marker but also a useful surrogate marker of the prostate volume and the progression risk. Serum PSA levels also predict disease progression, including worsening of the symptoms, acute urinary retention, and the need for the BPO-related surgery. The higher PSA levels, particularly more than 1.4 to 1.5 nanogram per ml, are associated with the increased risk of the benign prostatic enlargement or the benign prostatic obstruction progression, and may help identify men at a higher risk of intervention. The post-wide residuals, the amount of urine retained in the bladder after the voluntary void.
Faru,
Yes, sir.
do we do PSA in every patient with the LUTS? What is your message from previous slide?
No, if we are suspecting in a male patient who is more than 50 years, and we are suspecting the patient maybe have benign prostatic enlargement or the obstruction.
Is this the correct answer? If you will not do the DRE and you miss, if the prostate is hard, then you have to do the DRE.
Yeah.
If you are going for the surgical treatment of BPE, like TURP, TUIP, then you have to go for
repeat the PSA.
PSA.
Yeah.
Otherwise, PSA is not included in the initial assessment of lower urinary tract symptoms. Okay.
Okay.
Yes, it is not indicated initially when the patient comes to us with the lower urinary tract symptoms until unless we are going for a surgical procedure.
And if you are going for the starting of 5-alpha reductase inhibitors, then you have to do the PSA. Okay.
Okay.
So before starting DUDART, you have to have a PSA in your hand. So then you will start the 5-alpha reductase. For Tamsuline, you don't need to go for PSA, but if you are going for the starting of the medication of 5-alpha reductase, then you have to have a PSA in your hand. Okay.
The post-void residual urine, the amount of urine retained in the bladder after a voluntary void, normally there should be
कितनी
no.
स्लाइड्स रहेगी फारूक आपकी?
Post-void or Euroflow?
मदार साहब कुछ
डॉक्टर मजाहिर, अब आपके कंक्लूडिंग रिमार्क्स चाहिए मुझे।
मदार साहब कुछ बोले सर।
ये जो
Assalamu alaikum to all my gurus, Professor Murli, Professor Munawwar, and Dr. Tanzil. आप सबको बहुत सलाम. Concluding remarks here, number one, it's a very good discussion, and for the residents, this is the major subject, one of the major subjects in urology, and it cannot be understated how important enlarged prostate or low urinary tract symptoms is. The first point or the first talent that you need to acquire in assessing a patient of low urinary tract symptom is the history of the patient. You need to bring down this big umbrella of low urinary tract symptoms down, and you need to prove that this patient voiding symptom is because of low urinary tract, is because of enlarged prostate. For example, if you have a patient who is 70 years old, hypertensive, ischemic heart disease, and he comes to your clinic, do not rush that he has prostate enlargement just because of a report that says 35 gram prostate. He might be his urine incontinence or his polyuria or his nocturia might be asserted with hypertension, diabetes, even medications like Lasix that he might be taking for his ischemic heart disease. So the talent is taking the history of the patient. The next is the examination, and of course, then you have the armamentarium of your investigation. But I would stress that the most important is the history of the patient that would bring you towards the cause of the lower urinary tract symptoms. So the BPH is now an integral part of a new domain known as integrated men's health, in which you have multidisciplinary care, including cardiovascular, including medical team and the urologist, which all come together just for this one purpose of improving the men's health. So it is the bread and butter of urology, undoubtedly, and talent for diagnosis and its management should be acquired by every urologist. And for the residents, it should be on the fingertips.
Right, sir. Thank you.